Welcome everybody to the Teaching Value Learning Network. This is our monthly YouTube series and podcast where we talk to innovators from all over the country who are working on improving care. This is part of our wider Teaching Value Learning Network that has three components. We have this monthly series that all of you are watching right now with both on-the-ground and national leaders. We have discussion groups, and we share tools with educators and other innovators around the country. This month, we're very excited to have two national leaders from an organization called Providers for Responsible Ordering. We have Anthony Accurso, our faculty leader based at Johns Hopkins Bayview Medical Center, and Sonali Palchaudhuri, who is the resident leader at Johns Hopkins Bayview Medical Center. We'll be diving into a discussion with both of them about how they started a project at their medical center that's now become a national movement. Anthony and Sonali, thanks so much for taking the time to talk with us today.
Thanks for having us.
Thanks for having us, Neil.
So maybe just to get things kicked off, you can tell us a little bit about PRO, the organization, and your roles.
Absolutely. So we're really excited. So the mission of PRO, Providers for Responsible Ordering, has been to, provide kind of a network or a method for introducing high-value care to providers, as well as a way to kind of engage and see how we can do this as a group effort for our patients. So really the mission is to provide patients with the care they need and none that they do not, and enforce that through educational interventions, projects where we can focus on particular ordering patterns that we see can be improved upon, as well as just as a general idea of culture change in which those two are, they're all kind of aspects feeding off of each other. So Anthony can give a little bit of a history of how our group evolved over the past couple of years and what we found useful over the past couple of years.
Yeah, great. Maybe we can just start with just the origins. And I think actually when we were starting Costs of Care, Anthony, I think what I recall is you were already there. I think we connected right early in this sort of larger movement to improve value. So yeah, take us back to the beginning.
Yeah, so back to the beginning. So this really all started in 2009, a year before I got to Bayview. And per legend, there was a morning report at which a patient was presented who presented with right upper quadrant pain and characteristic LFT elevations. They had a right upper quadrant ultrasound, which indicated cholecystitis. They then, in the ED, went for a CT scan, which again showed a cholestatic problem, cholecystitis. And then before the patient went for surgery, a HIDA scan was ordered by the surgical team, which again showed cholestatic. And so this case was presented, and then there was a pause in the morning report. And so this really shouldn't happen. This kind of duplicative testing is not helpful. And in that morning report, it was decided that a committee would be formed at Bayview to try to address it. So that committee then went hunting for easy targets where there were known guidelines that were not being followed on our campus. And the first project that was selected by Jeff Trost and then resident Mark LaRochelle. Jeff Trost being a cardiologist here at Johns Hopkins Bayview, and the project was cardiac enzymes. And at that time, troponins were being ordered more than 3 times occasionally on a patient. And CKMBs were being ordered at the same time. And I believe that actually, so Jeff Trost had some collaboration with the Costs of Care on this project, as you had alluded to earlier, Neil. And so there was an effort on our campus to then do education through a grand rounds, a note card campaign, a pocket card campaign, and then notably a change to the physician order entry system that would put up a prompt that said CKMB is no longer indicated. And this was based on a good ACC-AHA guideline from 2008 that said when troponin is available, CKMB adds nothing. So this first Bayview Pro project ended up saving $1.2 million in charges because the total number of CKMBs went to nearly 0 in the institution, and the total number of troponins decreased. And notably, there was no change in the rate of ACS diagnosis. The thought was that if we were missing any ACS, it certainly wasn't any kind of clinically important syndrome because people would declare themselves. So this project was heralded as a model for how to approach things. This was transpiring while I was going through my residency, which I finished in 2013. Mark LaRochelle had departed for Boston to do fellowship. And so working with Jeff, I had asked Jeff, like, you know, I'd like to work on this pro effort as well. And right around then is when Sonali also arrived as an intern at Bayview. And she and I and a core group of others, interns in her class, set about restructuring the group at that time. I'll let her tell you a little bit more about it, but of note, one of the first things we did is we actually changed the name from Physicians for Responsible Ordering to Providers for Responsible Ordering so as to be more inclusive. And the vision that we had was that this might be able to be something bigger than Bayview. So
Okay.
I'll Sonali take the story over.
So maybe before we jump back into the story, just a couple things to highlight maybe from what you said. So the first thing I would say is I remember that original project well, and I think it was actually a project that was funded by the ABIM Foundation.
Yes.
Through a mechanism that was called, I think it was putting stewardship back into practice or something like that.
Mm-hmm.
You know, it sounds like maybe there was a morning report, or basically there was a case, like an index case that catalyzed a discussion. And then there was a project that grew out of it. And it was a research effort, but also a campaign. It was like a test of an intervention. And then that ultimately led to potentially a model where I think Sonali is picking up the story, where we're sort of thinking about maybe this is a model that could be replicated in other places. Before we sort of think about what the emergent model is and how to sort of think about it as part of a larger movement, I think one of the things that might be helpful to dig a little more deeper into is the original motivation for this. So there is duplicative testing that sort of caught people's attention. On the back end, there was an opportunity for savings. You said $1.2 million for this one commonly ordered test. But I think often when people think about value, there's a lot of things that they're sort of bundling up with it. And remember at the very beginning, cost was the last thing that anybody wanted to explicitly talk about as the motivation. There was this concern as if you put cost up front, that you're somehow skimping good care for the patient. And so just would be interested in hearing a little bit more about just, you know, what was it that was it the wasted effort? Was it the potential for harm? Was it all of the above? What was that original motivation, and how has that evolved over time?
You can speak to original,
Yeah.
I can say that well.
So originally, the index case that Dr. Trost presented at the grand rounds involved a neurocritical care patient who had a series of 23 negative troponins that were drawn over a 23-day stay.
Yeah.
And the argument was that, thank goodness, none of them were positive by chance.
Right, yeah, good point.
As such, you touch on an important aspect of our work here and yours as well, which is that when we have discussions about value, we really try to emphasize minimization of patient harm. And you know, at minimum, it's one less blood draw, which has a humanistic benefit. And at worst, it's detecting a signal that's not actually present that can lead to more intensive treatment that's unlikely to improve care.
That's really helpful. Thanks. You can almost think of those 23 tests as, we talk about near misses in healthcare all the time, but usually when we think about near misses, we think about the failures of doing too little to help be safer. But this is almost a near miss in the sense that, you know, there was a failure of doing too much, and we just avoided the positive troponin that would have led to a cascade of other harmful things. That's really interesting.
Precisely.
Yeah, and I think that speaks to when we talk about harms here, we do talk about financial harm, but I think our goal over the past couple of years has really been to structure our concept about medical harms and comfort harms as just as important, and if not more important than some of the financial harms that come with over-testing. And one theory that I've been working with is, you know, evaluating how over-ordering actually increases our chance for anchoring biases and just like does not improve our care, and at times worsens our care because it leads us down the wrong path. And so we really
Briefly, what do you mean by an anchoring bias?
In the sense that, you know, you have a test, let's say for this guy in the NCACU who has a positive troponin, and if you follow that and all of a sudden decide that he has an ACS event where he's really having a stroke or something, we're really led down the wrong path because of a test. And if your pretest probability was low to begin with, and the surprise if the result of the test completely surprises you, then we really should question ourselves if that's leading us down the right path or the wrong path in terms of what diagnosis.
So almost maybe another way of saying it is if you get a false positive result, it makes you and your brain almost double down on it.
Yeah, absolutely.
Right. Sometimes when the test is positive, that's the test's fault.
Right.
Not the patient's fault.
Right.
Blame the test, not the patient. Yeah.
That's right, and that's particularly true when it wasn't very likely to begin with.
Totally. Okay, let's dig into the good stuff now that I think the audience of this podcast and our community really want to hear about, which is how you get from this project to this grand ambition of thinking about it as a movement. And Sonali, I think that's where you were going to pick up the story.
Yeah, so I think when we came, I came with a bunch of interns we were all really invested in this idea, and as interns you're often told what to order and what you might not really agree with but put into, and so we started having a lot of conversations about what we felt was necessary for our patients and what we didn't really follow the logic for, and if we thought we could do better by our patients. So in the context of this model that already exists for doing projects, we actually wanted to make sure that we got back to the basics of not just discrete projects done by a few, but really making sure that this was a movement for culture change that involved more people, that had the investment of the greater set of providers as opposed to like a group of physicians doing a project. So that's a lot of what led us to our name change to Providers for Responsible Ordering, because we wanted to make sure that everyone who's involved in orders, meaning the nurses who draw the blood, the techs who do the all the different work, we're all really on the same page about how we want to manage our patients, and really highlighting their role in responsible ordering. So that was one of our big early efforts, or ways of signifying that effort. And the second part was we have a pro pledge, which we'll probably walk you through our website in a little bit, but it's basically just very similar to other pledges that are out there, a way for a provider to identify themselves as someone interested in high-value care and protecting their patients by thinking about their orders. And join this greater community and say, hey, we are in favor of this, and I'm interested in learning more about this and being involved. And it's along the lines of, if you sign for something, you may be, in your head at least, held accountable to it and really think about the merits of high-value ordering at the point of care. So those are the earlier things that we had done. And again, we wanted to make sure that we became not just a group. At that time, I think there were a lot of meetings happening with upper, like more powerful people. We wanted to make sure that frontline providers, the residents, the NPs, the hospitalists, had a stake in the game as well and felt ownership and investment over high-value care, for delivering high-value care. So that's really why we kind of stepped back, renamed, designed the pledge, and tried to make sure that we had meetings where everyone can come to and join the effort.
Great.
I wanted to chime in briefly on that. So we listened to the name of the group, which was then a committee at Bayview, and it's Providers for Responsible Ordering. And it sounded like something that could be bigger, something that it's more of almost a philosophy or an approach to ordering. And we looked at it and we thought about, how do we make this happen? What do we put in the pledge? And so when we actually put a fair amount of thought into what the pledge ought to be initially. And we said, well, maybe it should be 12 lines. I will never order a CKMB if I have a troponin. I won't order a chest x-ray in the morning if it's not indicated. I won't put a patient on telemetry if they don't need it. But zooming out, we began to think that actually a responsible orderer really should be thinking critically about any number of different clinical situations as they're clicking their mouse. And we designed the pledge, which I'll review quickly right now, to address that. So it's based on 3 tenets. The first is, will this test or diagnostic change either my diagnosis or my prognosis for the patient? The second is, are there any potential harms, be they physical, somatic, financial, that could come from this intervention? And the third is it consistent with what the patient wants and what the patient's values are? That's pretty broad, but we think it's powerful, and we think that people who click and sign the pledge are thereby expressing their solidarity in this movement, which we would generalize as being a movement about both high-value care and right care, protecting patients from unnecessary care.
That makes a lot of sense. Often the most powerful and the most scalable frameworks are the simplest and the most stepped back. And I think when we sort of think about what you've done, I mean, there's sort of two layers to it, it sounds like. There's one layer where you're helping surface, or just, there's probably a lot of people that tacitly think the same thing about, probably every resident that goes through their training is like, I'm spending my time following up on a lot of things I don't need to, or at some point. But you're resetting the norms a little bit by making it okay, and you're giving a space for people who want to identify as having aligned thinking to live. But there's a very good point, and I think in what Anthony just said, is that in creating that space, you also have to define it and set some parameters around it. And by having these sort of 3 questions that people are pledging to ask, you've by design, you've sort of set some of the boundaries around what you're talking about, but you've also, I think, created an approach where they're high level enough that they can really be applied to any clinical setting. And these are all part of design features of what you've done. By calling it providers for responsible ordering, you're including everyone. Mm-hmm. Theoretically, these are 3 questions that could apply to anyone who's caring for patients. Is that accurate?
Yeah, that's precise. That's precisely it.
So, I mean, I guess we can take this conversation now in a few different directions. I mean, we could take a look at the website and the pledge, but one of the things I want to make sure that we get to is thinking about how others who are out there can become part of that movement and also understand what they're getting into. So, the barriers, the challenges, and all of the sort of nitty-gritty that I know you guys have already started to navigate. So what would you guys suggest? Do you think it would be useful to have everyone take a quick look at the website?
Yeah, actually, that might even help explain a little bit of what we've been up to and how it goes about. You want to?
Yeah, I think that's fine. We're going to switch over. I wanted to show one thing, which is, in the sense that this is a culture change device, the Providers for Responsible Ordering chapter is a way of trying to introduce culture change in an institution. So ideally, folks who take the pledge also wear the Pro pin. We have a basket of them right here. But it's a very visible way of saying I'm someone who thinks an error of commission is actually just as bad as an error of omission. And it makes it safer for a resident to pipe up and say, do we really need to order this test? And so with that as a backdrop, we'll show you how you can, among other things, get these pins on your campus. Sonali will lead a tour of providersforresponsibleordering.org.
All right, so that's our website name, providersforresponsibleordering.org. And this is just our homepage. You can see that the map shows all the different chapters that we have right now. We're up to 9 chapters, doing fairly well on the East Coast. We have a lot of space in the middle here to fill for all you programs out there. But this is really here just to show, again, it's a movement. There are a lot of people invested in this who've really gotten under this umbrella idea of minimizing unnecessary and harmful tests. So the next page, on the top toolbar here is the pledge, and it's just the text as Anthony went through with the 3 main bullets. I will order diagnostic tests only after considering management and prognosis. For all intervention and treatment, I'll think about the additional suffering and potential medical and financial harm, as well as the benefits, and I will incorporate the patient's goals. And on the right side of the page here, people can sign up with their chapter or some other institution if they're not in one of the current chapters, signify what their interests are, because we try to, add a chapter, try to identify people who may be interested in specific types of activities. And then here, we do send out an email with some updates with news and links and events every once in a while, and so if they're interested in joining that, they can. There's also this option to join Pro Core, which would be the small group of more active residents and attendings at each campus or other providers. So the idea here is really to make this, it's a really low bar of how to join Pro. It's really, you just have to want to agree with the mission. And we want it to be that simple because we want it to be something that people can be easily included in it and feel part of the movement. But there are also options for greater engagement based on what your interests are. The next bar is our chapters, and each chapter has its own homepage with activity. Different chapters have used it different ways. Some have used it as a place to discuss their projects and the status of things. We can see the pledge signers by chapter here. We have a bit of a head start here at Bayview. So for example, our homepage has a list of our main ProCore leaders, some of the projects that we've been doing, and in the future we can add some of the status of projects, but it's kind of a place where people can go and see what's going on campus and how they might be interested in getting involved. The tag that I'm probably most excited about is our toolbox. And this is modeled similarly to the AMSA toolbox, where if people at a chapter are interested in learning from whatever happened in a different institution or using some of their tools, it's available on their website. So we've kind of replicated the same here. So we have a few different projects that have been running here with the pocket cards as mentioned, and I'll just click on the troponin pocket card real quickly, that if other institutions wanted to use, they can, and they're encouraged to. They don't have to reinvent the wheel. We have some references, put together like a lit review. We have some guidelines that people can look at, resources that we put together and make the project work. The top of it, since this is for value teaching, it's also a collection of educational projects and tools that we've collected from around the country. I'll highlight the Costs of Care Teaching Value Project, as well as the High Value Care Curriculum from ACP and a few other things that are available. But again, trying to create like a hub and a place where people can go to look for these resources so that they don't have to start from the scratch. They can start with the tools that have already been developed. Resources has some other useful things for providers at the point of teaching, as well as some educational things. So I'll put, for example, sometimes finding the Walmart $4 list takes a couple of clicks and you can get it straight from here. So we're trying to make it useful for providers as kind of a station for where to go. We've been trying to build a list of some of our more scholarly work and showing that that there's been changes in care because of this culture change and how we've been able to talk nationally and locally about it. And then, of course, reference, if anyone wants reference about high-value care, we have different articles for people just getting started. So that's kind of a quick overview of our website, and I think that might help highlight our kind of threefold mission, which is we want to go about encouraging high value by specific educational interventions, projects that have educational components, but also engage the system at large, and culture change, which really depends on those two other things, on having good educational projects and activities, as well as projects that get people involved, but also just this greater idea of wearing a pledge tag and signing the pledge and getting the newsletter and all that kind of stuff.
One of the things that I'm seeing is you guys you're rooted largely in academic medical centers. The model is very much centered around faculty and trainees, and there are a lot of benefits, I think, to that model. One of which is, as you think about culture change, you have to use sort of the tools of advocacy, which means coalition building, creating a platform for networking, wearing the pins, retail politics and campaigning and all that. Then on the other hand, because you're rooted in academic institutions, one of the features that you highlight on your website is that scholarship comes with it, which means thinking about evidence base, yes, the posters and the cool looking graphs for the folks that are watching on YouTube in the background and all of that. And so often the most impactful interventions in real complex healthcare systems require both. Mm-hmm. You have to build coalitions, but you also have to have objectivity and measurement, and show that you're saving $1.2 million. So I think that's a powerful feature of what you've done. When I think about sort of the success metrics to highlight what you've done, it may or may not be dollars and cents, but one of the things is you're accruing members, which is an important part of building a movement. When I look at your toolboxes, you're also accruing use cases of how this type of thinking can benefit patients, and in granular terms what that could look like. And so there's a lot here that I think is exciting to me as someone who's been really interested in this space, and I think will be exciting to a lot of other people who are just learning about it. I think one of the constituents out there, in addition to the people who are just learning about it and the people like us who've been entrenched in it, are the kind of people who are on the fence and may or may not be in an environment yet where they're ready champions. And so if you could talk a little bit about how you think about the barriers to entry, particularly if you have any experience with that for people who've started up new chapters, whether it's entrenched resistance or unintended consequences or concerns about any of the above.
That's a great question. And I think our goal has been to make it as easy as possible to join this effort. So, for example, even if you don't have a chapter at your home institution, sign the pledge. You'll get our newsletters. You'll at least feel like you're part of this greater network. And so, while you're right, I think a lot of our strength is in having this component of, academic currency with scholarship as well as political currency with people and people signing at an institution. It's also just this idea that people can engage from wherever they are, even if they don't have that home set up. But in terms of particular chapters, if they've had barriers, I'll say one of our strengths here at Bayview is that we have a lot of buy-in from our chairman of the Department of Medicine as well as the hospital administration. And what that means is, if we want to discuss one of our projects or educational things at ground rounds, we have that floor. If we want to, work with the people in IT to change the order sets to better be aligned with guidelines, we can, try to engage people to do that. And what we really encourage other chapters to do as well is to move away from just being, a band of brothers who like doing something to really engaging the hospital network and their institution at large so that they can actually get the wheels moving to make change. And I think that does vary from institution to institution. There have been a couple where, there might be people interested, but they don't feel like they have the support from higher above, and that's been a little bit harder to get through. But so far, people have been successful in getting the message across.
Yeah, you've been in this game for a while. Do you have any wisdom to share about that specifically of trying to maybe not go as far as converting people, but whether maybe a softer way of putting it is identifying the champions that do exist?
Yeah, that's really interesting, Neil. And I had done organizing work before this, and what I find is that there are people at your center who are willing to work really hard, and those are what we call our pro core. We expect and have seen that every chapter has 1 or 2 people, maybe 3, who lead it, 4 or 5 who really show up. But then there's this wide net of people who may not actively engage in it, but may be swayed by the culture. And so by having the pledge, if you have 30 people sign the pledge, as the University of Michigan just did, then you're tackling one of the barriers to high-value care, which is just that people, that people know about it, and you're giving it a language. And we start hearing things like, oh, there may be a pro-project here. And that's how it starts. We've had barriers. It's not easy for us to get our hands on data. People aren't paid for that here. And we haven't been sufficiently strategic about trying to make it clear to the hospital that it might be in their bottom line's best interest to do this work. But we have been appealing to people's intrinsic desire to do good medicine. And that seems to be powerful.
Well, that's a really great note to end on. This is really, really inspiring work. It seems like this is something that folks have been thinking about for a while, including you, but it seems like it really has legs right now. And whether it's probably a combination of your sort of strategic thinking about how to build this movement and maybe the timing and the window of opportunity. But this definitely seems like the right moment to scale up this effort. And I think all of us are going to be very excited to sort of see what you do with it over the year to come. So thank you so much for taking the time to talk with us.
Yeah, no, and I mean, Neil, on behalf of PRO, we'd like to thank Cost of Care, we'd like to thank the ABIM and the Teaching Value Learning Initiative. And we do want to emphasize it's easy to start a chapter. Sonali and I are both reachable on email, and we're happy to answer any other further questions. And we've been enjoying watching the great work at Cost of Care from here as well.
That's great. And if it's okay with all of you, we will share your contact information as well as your website on our learning network following this webinar and podcast. So thanks so much to everyone for listening, and we'll see you next month.
Thanks so much.
Thank you.